We spend $100 billion on a global basis to try to diagnose cancer. $100 billion between imaging methods and laboratory procedures like standard pathology reports. And so despite that $100 billion, we still have this problem of so many people dying from cancer. And so why is that? Why is it that even though we spend this amount of money to try to diagnose it, we still have problems getting to where we can start to cure this disease? And you've probably heard some of the other presentations yesterday and today from companies that are working on therapies. Our primary concern is how do we diagnose it so that we can get the appropriate treatment to patients. This article was recently written, just as recently as October, from the American Cancer Society. And the opening paragraph tells the story. The opening paragraph of this article tells the story, and that is early detection is the problem. For most cancers, they are largely asymptomatic until it gets to be too late. And so the problem becomes our choice of treatment for many cancers is restricted because we don't get to it or identify it at an early enough stage. And if we could only identify it earlier, we would have an opportunity with improved treatments because you can treat the cancer when it's a smaller problem. So why is that? Why is it that we don't have the ability to detect cancer early enough to affect treatments? And that comes from the current methods of cancer identification right now. There are primarily two modes. So if you look at the American Cancer Staging Manual, there's three things that you need to identify. You need to identify the local tumor growth. How fast is it growing? How big is it? You need to identify whether it's spread and whether it's metastasized. That's the way that you currently diagnose and stage cancer. And our primary methods to do that today are largely standard clinical practice, going to your doc and having him examine you. We have imaging methods like MRI, PET, CT scans, and the like. And we have more laboratory-based procedures where we take a pathology sample, a biopsy or a surgical sample, and we take it to the lab and we analyze it. And there's lots of things being done today to look at molecular diagnosis of cancers where we can, actually, a company I used to work for, I could give you a single cancer cell from blood and do the entire next-gen sequencing on the single cell level. That's a laboratory procedure where we were looking at the heterogeneity of cancer, right? But the problem with both of these current standards of care is, on the imaging side, they lack the specificity and they lack the sensitivity. So you're probably familiar with a standard mammogram, right? I can see that there's a lump of tissue there, but I can't tell you if it's benign or malignant. It might be a fibroidal mass. All I know is that it's different than the surrounding stromal or breast tissue, right? Same thing for MRI and most of the current methods of imaging. I can tell you that there's something different about the tissue. Maybe its metabolic rate is different than the surrounding, and that would suggest that it's cancerous. But I don't actually know. So what we rely on then is some kind of surgical procedure to extract some of the cancer cells, a biopsy of some kind, and then I go into the laboratory and I do the analysis. Well, those surgical procedures, they're all invasive, right? So today our problem is that we don't have ways to detect it early by in vivo or in the body. And even if I can detect things in the body, oftentimes I don't know exactly what I'm detecting. So the only thing I have now, the other recourse I have, is some kind of invasive procedure. So what's needed in cancer diagnosis is ways that are non-invasive. The ability to minimize invasive procedures would be a good thing. So if I could actually identify the presence of cancer and know what kind of cancer it is in the body, now I can combine the positive attributes of the imaging methods and the pathology methods, and I can get to a non-invasive, specific, sensitive measure. So the graph on the right is probably something everybody has seen, now, this concept of personalized medicine. More than 70% of the oncology therapeutics today are targeted at a subpopulation. So this idea that we're going to give everybody the same cancer treatment and it's going to cure everybody is gone, because we now know that cancer is highly heterogeneous. It's different in different people. Everybody's cancers are slightly different. And so the idea of personalized treatment is really coming into play in the cancer space. Well, in order to be able to get that, I got to know what specific type of cancer you have. And today that's done by a pathology biopsy sample that I go into the lab. But if we could get to where we could tell people, you have this particular type of cancer in a highly sensitive way and do it in the body, we now have a way to non-invasively get to early cancer detection without it having to be an invasive procedure. So we think we have that at Senior Scientific with a technique we call magnetic relaxometry. Sounds pretty sophisticated. It's actually one of the most elegantly simple concepts I've seen in my career. One of the reasons I joined the company was I loved how this technology actually worked in its simplicity. So we start with the idea that we're going to give a low dose of cancer-specific nanoparticles to the patient. Right? So I have iron oxide nanoparticles, and I'll go into a little bit more about how this works. Iron oxide nanoparticles that I'm going to give in a low dose to the patient, but they're cancer-specific. I have antibodies coupled to the nanoparticles that specifically target the type of cancer. So if you look at the picture on the right, you'll see that the nanoparticles are going to go in and they're going to circulate. And the cancer-specific antibodies are going to then stick to the cancer cells that they're targeted for. If you don't have that type of cancer, the particles are just going to remain in circulation and eventually get taken out through the normal metabolic process in the body. But if they stick to the cancer cells, because the antibody on the particle is targeted for the particular type of cancer, and in this case we would be illustrating, for example, the spread of HER2-positive cancer to the lymph nodes. So if the person had been diagnosed with HER2-positive primary tumor in breast cancer, before you do anything, you want to know, has it spread someplace? So we would give an injection of anti-HER2 nanoparticles, let them circulate, and if the cancer has spread to the lymph nodes, we would be able to detect the presence in the lymph nodes. I then take the patient, lie them on a bed, kind of like an X-ray machine, center them under our detector, and I'm able to measure then the presence of the nanoparticles that are stuck to the cancer cells. It's what we call an ultrasensitive detector. It uses something called SQUID technology, which is super quantum interference detector. Sounds really sophisticated. Basically, it's a way to measure magnetic fields. Unlike MRI, we don't require a shielded environment, so I don't have to have a $2 million hospital installation to do this. We use an ultrasensitive detector that basically eliminates all the background magnetic field. And it's highly sensitive. We're about 2 orders of magnitude more sensitive than current imaging modalities. So if we can get to where we can now dose a patient and we're able to specifically have particles that target a particular type of cell, and I have the measure of sensitivity that's 2 orders of magnitude more sensitive than current imaging modalities, we can get to where we have non-invasive, molecularly specific, targeted cancer detection, highly sensitive. So we can get to early cancer detection, and we know what type of cancer it is in a non-invasive way.